to the legends in cardiology, not only in India, Asia, globally. It's really a great occasion for the participants to, listen to the, concepts in the future towards the future of cardiology. It's really a great occasion. I have great pleasure in welcoming the icons of cardiology and cardiothoracic surgery. We have here Dr. Ashok Sheth, who is one of the pioneers in interventional cardiology. His articles have got the Gilka Book of Records, and we all know him over 35 years. He is in the field of interventional cardiology. It's so nice he could spare some time.
Thank you.
To discuss about the future of cardiology. Yeah, we all know cardiology, not only cardiology, every medical science is evolving every day, and cardiology is a science which has evolved much, and every human born on this earth now has to see a cardiologist. That is how it goes. Whether it is a cardiac problem or non-cardiac problem, he has to see. And every higher specialty institution, cardiology is in the forefront. Without that, it is not going. That is the importance of cardiology today. That is why we have this seminar, and we are so happy to have Dr. Ashok Sheth, now Dr. Ajay Paul, who is one of the veteran cardiothoracic surgeon, and his passion is for cardiac transplant, which all of us know. We would like to hear from him what is going to be the future of cardiothoracic surgery beyond a valve replacement and ECMO. And we have our Mohanan from Thrissur. So nice to see you, sir. And we like to hear your view where the cardiology is moving and where will we be. A few pointers I would like to place across, but we would like to listen to you all more. Now, leaders of cardiology, we will touch upon a few important evolving aspects of cardiology and cardiothoracic surgery. First of all, today it's an era of digital era. Our Honorable Prime Minister has said it's a digital India. And COVID, amidst all its negatives, has given a positive that we are able to digitally see the patient. And not only a consultation and a follow-up of the patient, and even now interventions are also happening digitally. All of us know well. And where will we stand on the remote monitoring of a patient? I still remember very well, one of the VIPs of Mumbai had 3 stents inside, and he was sent home. When he was trying to come down from the lift, he collapsed. Luckily, there was a doctor inside the lift, and he could do a CPR, and immediately he was transferred, and a pacemaker has been placed inside him. I was just discussing with the cardiologist those days how to remotely monitor. See, with a lot of difficulty, it's not an easy thing to place a stent inside. I have seen it myself. My team is doing it always. I know how much of efforts we put in, how much of suffering the patient also undergoes. But how to monitor it? See, we have placed a biventricular pacing, or we can place a left ventricular assist device, or a stent, or even a CFBG surgery. It goes from our hands. Now it is a concept, or the policy is an early discharge. How to remotely monitor this patient? I used to say every institution should have, IT department, health IT department. All the data that the patient leaves from our hands, whether he is any part of the country, should be monitored in that department so that any changes could be immediately intimated and an intervention could be done. We would like to hear the views of Dr. Seth on this.
That's a very important question. And I think it's actually not just the present, but also the huge future. And let me just explain that over the last 20 years, we've seen, leave medicine aside, everything is remotely done, executed, and monitored. And we're talking about telecommunication, we're talking about handheld devices, we're talking about the net, we're talking about the World Wide Web. You see, everything that we do today, we order even a meal that is remotely. It will get delivered, but every information is remote. So if we actually start thinking ahead, even what's happened over the last 10 years is because handheld devices have gone cheaper, technology has improved, we're able to connect in most areas on the Wi-Fi. and speed of everything has gone faster. So till just before COVID, we saw certainly huge advancements in remote monitoring. For example, heart rate monitoring, heart rhythm monitoring. We've already known the fact that there are watches which now monitor atrial fibrillation. But I tell you what's happened in the last 2 years. COVID has been truly influential in what was an option earlier, what was something which was getting developed, what was something which had some time in the future to perfect, has happened rapidly and fast, because COVID not just made it optional, it made it essential that remote monitoring becomes a standard practice and a part of life. And I'm not just talking about telecommunication consultation, but improvements in artificial intelligence have happened so rapidly in the last 2-3 years. Improvements and decrease in costing of handheld devices and telecommunications have happened so, and widespread telecommunication, that now we're not just able to monitor EKGs. Future lies, we also be able to predict heart failures. We're able to actually, just like remote glucose monitoring, we are able to monitor NT-proBNP levels. This has to be perfected into being fed into a system which, due to artificial intelligence, would respond to the patient instantly, even before it gets to the doctor. We know that it gets to the doctor through the clouds, but there is a lag phase. And this lag phase is going to be improved in the future by artificial intelligence, so that actually real-time advice can come to the patient on, say, EKGs, on NT-proBNP levels, on the heart rate, on heart rhythms, even predicting arrhythmias based on artificial intelligence, and even predicting heart attacks based on artificial intelligence and the rhythm disturbances. So I think we're moving rapidly ahead. The future lies specifically in terms of personalized medicine, and clearly home monitoring and remote monitoring will be a part of personalized medicine.
Thank you so much, Dr. Seth. Dr. Mohanan would like to give your inputs on this.
No, you were citing an example of a person with a pacemaker. In fact, our electrophysiology friends started this remote monitoring business. They were much ahead of us. They started, in fact, even in 2010, there was a trial called Trust Trial from the United States, where they found that the average time from the onset of an arrhythmia by the clinic, to the clinician's evaluation can be considerably brought down by remote monitoring. And as Professor Seth has said, now we are living in a something called the Uberization of healthcare. Now the patient, the doctors are going to the patient. The patient has the absolute power in his hand. So I think it's a fantastic evolution, and I absolutely agree with Professor Seth about the statements he made.
Thank you so much. Uberization of healthcare is an excellent, innovative terminology which fits in so well. See, we are talking about the diagnosis of a remote diagnosis of a cardiac event or irregularity in the system or at the rhythm. Is there any effort that has been taken to intervene on the therapeutic side distantly? You have made a ventricular fibrillation in the patient. Is there any opportunity or any trial that is taking place to, intervene to give a defibrillator on him? There are some efforts which I have read, I have seen also. I think we'd like to hear from Mohanan and Seth.
And absolutely, the trial I mentioned was done in 2010, and they showed that you could prevent cardiac deaths by remote monitoring. And we have over the years, I think at least 70-80% of our devices that they implant, especially CRT or the other more ICDs, which will require more closer monitoring, are managed remotely. And the earlier, one of the problem was there were too many vendors. Now you have Medtronic, you have multiple companies, and there was some confusion in that. Now we have a group called, and the EP group has all joined together, and they are coming out with the solutions. And I think that is the way to go, because deaths happen so suddenly. Dr. Sid.
No, I think you're so right in saying all that. additional thing which has happened is that these remote monitoring has grown cheaper and cheaper. We must remember that. These things used to be expensive tools, large tools, available to a few. But believe you me, in the last 3 to 4 years, the costing is going down, the availability is going up, and the linking it up is becoming easier and easier because of the spread of Wi-Fi all over the place. After all, many of these devices, in fact, every device functions based availability on the net. And net is become now public, universal. India itself, today, our Honorable Prime Minister is singly talking about one thing, that everyone in this country should be net enabled. Now, that is a huge step forward in any remote monitoring that we can talk about. So I think we're heading rapidly. Yes, you're right about prevention of, if you are able to, and I actually still believe more artificial intelligence needs to come in. You can't have that lag phase in which a doctor responds. Finally, it has still got to be a doctor. After all, human mind will always be better than artificial intelligence. But instantaneous responses will become the future. For example, an ECG starts showing mild ST segment elevation from a previous ECG. Patient still not having a chest pain. There is 7 million ECGs which are fed into a computer, which immediately warns the patient that, hang on, your ECG became abnormal, which we know has a 50% chance of proceeding to an infarction. Now, that is the sort of information that I actually needs. That is not going to wait for a doctor's OPD to finish and the doctor to come back and say, wow, your ECG suddenly shows a heart attack. I hope you see the difference. So intermediary of artificial intelligence will have to come in with instantaneous. And that's where the world is progressing, be it for ECGs, be it for brain scans for people who have strokes. They can't wait for a CT specialist to start seeing scans. It has to be artificial intelligence. I'm not saying we've got to rely on artificial intelligence, but I think we've got to start using artificial intelligence judiciously so that lag phases disappear in human interfaces.
Thank you. I totally agree with you. Artificial intelligence is machine intelligence. Yes. And the major advantage is who will go for a myocardial infarction and who will go for a cardiac failure. Which VPC can go for a VTAC or, ventricular fibrillation. That's a prediction of the bad outcome is always the advantage of AI. I agree with Dr. Seth that, of course, it cannot replace human brain, but still it gives some rest to the human brain. There was a conference in Singapore on IoT, that is the Internet of Things, wherein cardiac things were all linked there. They had some small drones, and when there is a sensor, the remote monitoring is done through sensors. When the patient discharged, we put a sensor on his chest. Now, about 4 weeks ago, I saw a sensor which can be put in the forearm. It gives 14 parameters, including a pulse oximeter, blood pressure, pulse rate, and rhythm, and his oxygen saturation, his adherence to drugs, and his calorie intake, how much expenditure, so much is coming. If you put it there, it was costing about 15,000 rupees. Probably it will be available so soon. When we discharge the patient, he goes with all his data are recorded here, and it always gives, you set the norms. When the pulse rate is above 90, it has to, give the information, it does it. And these drones, through these drones, once you have diagnosed a ventricular fibrillation, which can reach to the site within about 4 to 7 minutes, and it can give a, DC shock there. Right. And that is the way they had planned it. It is yet to come to medical utility. That will be a great boon for the clinicians and cardiologists. As Seth was telling, perception of the pulmonary, the wetting or the water level in the lung fields can be monitored. That can tell you, oh, young man, you are going in for a cardiac failure. You reach to your doctor. Informs the doctor, your patient is going for, a lung, a pulmonary edema. That is how things are going on. We would like to hear from Dr. Ajay Kal, sir, your views on the use of artificial intelligence or digital technology in the diagnosis and management of cardiac problems. I'm sure all of us agree that is going to be the future. I was listening to our IT expert from India, Mr. Pichai, who had passed on a video to all the people how artificial intelligence can support the clinicians, especially the cardiologists. We would like to hear from Dr. Ajay Paulson.
Thank you. Pleasure to be with Dr. Seth. I always
Thank you,
admire.
Ajay. Thank you, Ajay. Good to see you. Good to see you. Always a pleasure. Wonderful seeing you.
Yeah. So let me tell you one thing, which is very, very important. I'm really impressed with the way Indians use internet. Even if you go to a small village anywhere, today they have smartphones. And with these smart watches, it reminds me of one incident that happened today in the morning. I had operated a patient a couple of days back, and he suddenly calls me, "Sir, I have a watch on my hand which monitors my heart rate, which was always 80. Today there is something funny looking, and I'm not very happy with it." Can you believe? I just told him, take a picture and give it to me. Now, he's not from Delhi. He's from a remote village in UP. He sends me a picture of that. He records a video and sends me, and I know it is atrial fibrillation. I tell him, this is amazing. We are discussing it today. I tell him, okay, go to a nearest doctor. He goes to a doctor. He tells him, okay, the doctor talks to me and tells him, "Sir, what do I do?" I tell him, okay, we give him a couple of medicines. I tell him, you can give him Cardron, this, that, and he is cured. Now, this is the beauty of having these remote monitoring devices. And India is really very literate in so far as these devices are concerned. Mobile connectivity is concerned. We are very good at it. And with 5G coming, artificial intelligence will be in the forefront. At the moment, if you ask me what is the problem, is problem in the connectivity. We have to, as Dr. Seth rightly pointed out, we are working more and more in good connectivity, and that will give us an edge over others. Now, so far as we were talking about this heart failure thing, see, monitoring impedance tells us about the fluid monitoring. There are devices which we put in the pulmonary artery to monitor pulmonary artery pressures. There are pulse oximeter. There is all sorts of things that has come, and simple like blood pressure monitoring. You have on your watch. And how do you prevent these things? A hypertension can be managed immediately the moment a patient comes to know that his pressure is shooting up. I'm talking about a simple device that is an electronic watch. This makes all the difference. Now, so far as artificial intelligence and managing this is concerned, it's going to replace everything. It's just a matter of time. Let's talk about echocardiography. Let us talk about radiology. Today I was talking in morning to one of my colleagues. He is sitting somewhere in Hyderabad and managing reports, radiology reports from all over the world. And most of these, what was amazing is through artificial intelligence, many of them have been scanned. He says that 90% of the report is ready. It's only for him to just authenticate it that, okay, these reports are okay. This is how things are coming to. Echocardiography, most of the diagnostic reports and other things will be covered by artificial intelligence. So the future of medicine lies with artificial intelligence. We going more for 5G and other connectivities, because unless we have a good Wi-Fi and connectivity, these things will not work. Fortunately, in our country, many people are now connected with Wi-Fi and internet. So I think future is bright for artificial intelligence and remote monitoring. Thank you.
Just one word, sir. Now, as somebody said, there are possibly more cell phone in the world than toothbrushes. And we live in a planet of cell phones. You are mentioning about the wearables. It's believed that more than 1/4 of the sales growth in the personal health monitoring devices is the wearables. So, not to speak of Professor Seth was talking about the importance of the artificial intelligence and deep learning in getting ECG. Now you can predict the ejection fraction from ECG. You can even predict your age and sex from ECG. So I think the AI and is the in thing, and we have to possibly learn more and more machine learning.
Correct.
Sure. Intelligence is going to overrule human intelligence.
No, it's not going to. Just on one point.
Please.
It's never going to overrule human intelligence. It's going to be the interface between the patient and human intelligence, because human intelligence expertise cannot be available to 100% of the patients all the time. I think the issue is that is always going to be the human intelligence which will overrule artificial intelligence. After all, artificial intelligence is there because of human intelligence. That is what has been fed into the computers, that experience, that expertise, that deductions, that diagnosis is what human intelligence created, which has been fed into artificial intelligence. And that is why artificial intelligence works. It works on the reports which humans created to say 7 million ECGs reported by humans. And that is why the artificial intelligence can predict what is this? What does this actually mean? What does this ST segment elevation of a millimeter mean? What does this T wave inversion mean? Because it was human beings who actually put that diagnosis. So yes, it'll be the right interface for instantaneous advice, for screening, for deduction, for immediate treatment to get over the lag phase. But finally, the human intelligence will always be there, because 5 years from now, artificial intelligence will get outdated because it's the human intelligence which will feed it to say, well, what we thought was ST elevation of a millimeter is no more myocardial infarction. We have reviewed X number of ECGs, and therefore what you got is wrong. Now start relearning what this new knowledge is. So I hope you understand, artificial intelligence will not be static because human intelligence will continue to grow.
Sure. I totally agree with Dr. Seth. It cannot replace human intelligence. It can only support human intelligence. It was brought in by human brain. It cannot take over human brain. Totally agree with you. And now we are talking about a remote monitoring. Now in the major advancements are taking place in 3 areas in cardiology. One on the cath lab side, 2 on the cardiac surgery side, 3rd on the cardiovascular therapeutics. We'll just discuss a few things on this, what will be the future. From the cath lab side, what could be the advancement that you expect? Can be a 3D cath lab, or there are some, I report that the catheter placement in an ablation therapy can also be guided by artificial intelligence. We'd like to hear from Dr. Seth.
Yeah, I think the human expertise in these procedures will always remain the most paramount. What will happen is that whatever advancements happen are only making it easier, firstly, so that it's only making it more precision-based, so it's more precise. Thirdly, that it is giving an ease of functioning. Therefore, for example, you're able to superimpose images one on top of the other to be able to do things more efficiently and faster and with precision. And finally, everything is going to give the patient the best outcomes. But it's not going to replace the individual. We've seen that every advancement which says, finally, the patient has to benefit from it. The two people have to benefit. The doctors, in terms of less radiation, ease of technology, ease of functioning, and having multiple modalities so that they get a 3-dimensional structure of what they're doing. But finally, the fingers will be there. Secondly, the patient to be benefiting from best outcomes. And thirdly, is going to get more minimally invasive. When we put the 3 together, we have the future, we have the present, and we have the future. That's where the world is going.
So nicely you explained on the future of the cath lab that has to be there with the utility of artificial intelligence. We'd like to listen to Dr. Mohanam.
Earlier again, Professor Seth also was mentioning about we have now robotics are coming in a bigger way in the cath labs, and we have from India also. We have a couple of centers which does that. As he absolutely rightly said. See, as we grow older, we can't stand in the cath lab for a long time. So we can, why not use the robots? Prevent radiation. Radiation is one of the real villain for us cardiologists and anybody, and not the cardiologist alone, any imaging person, because it's a big dissuading thing. So why not? It's definitely a possibility. And possibly the second area where in the cath labs where we are seeing more and more structural intervention. See, we are seeing more, apart from the coronary intervention, we are seeing aortic intervention, valvular intervention. So the concept of 3D and the printing, see, 3D printing is coming in association with the VR technology. virtual reality and 3D printing is making our lives, it's much possibly very useful for the surgeon, but even for us. I was just in the, I went to Amrita Hospital a few days, my relative was there. He's a professor of pediatric cardiology. So he was very much interested and he showed me, because if the conventional 3D, they are all costly. So what you do is you acquire 2D images from your MR, your CT, then use machine learning, artificial and VR and convert everything into a 3D. And you can go into the vessel, you can go into the valve, go through the valve. I was completely amazed. So, it is not the surgeon alone. I think we can also learn from closing the VSDs or device closure and even stent graft positioning. Everything can be eased up by 3D printing. That would be another area where we will be benefit.
I agree with you. When you see a 3D image navigation in cardiovascular intervention, especially a stenting placement or a valve replacement, a TAVR, it is really, exciting to see that. As though we just go through a big, channel, we are able to see that, and it makes the job of the cardiologist so easy to do these interventions. The 3D image navigation, I happen to see that some of the pictures, so interesting. And thank you so much. We like to hear the views of Dr. Ajay Kaul. Where all the future of cardiovascular surgery is going on. We were doing a sternum, we were doing a transthoracic CABG. We were doing an AST closure, which has been now a device closure has come. Valve replacements are being done, catheter, transarterial, and now pericardial. These things are going on. Robots are going on. What do you feel the future of cardiovascular surgery? Here, what these digital technology and AI or IoT are going to play? We like to hear your views, sir.
Definitely. See, the aim of any surgical procedure, it may be, say, for example, aortic stenosis. These days, we have an option. We can go for midline sternotomy. We can go for minimal access surgery. We can go for sutureless valve, and we can go for TAVR. So, I look at it as treating a patient. It's not that it's a surgical thing, and ultimately, the way things are moving, I am a strong proponent of transcatheter procedures, and that's the future of treating heart conditions. Let it be VSD, let it be any other ailment. And I was seriously thinking about something. Ultimately we say left ventricular assist device for left ventricular failure. Why can't this device be put percutaneous? That is what Impella is. And a better form of Impella can keep a patient surviving for years together. Why not that? Only the technology has to improve. So this may be music for Dr. Seth and my other colleague, Dr. Mohan, but being a surgeon, I believe that you have to give less trauma to the patient. I don't like when I do open heart surgery. That is primitive surgery. What the future of any surgery or any treating the cardiac condition is, it should be percutaneous. There is a comparison between gallbladder surgery. There is nobody does opens abdomen for gallbladder these days.
Yeah.
Similarly, cardiac surgery has to evolve. It has to come. Now, you were talking about robotic surgery. See, let me tell you again, robotic surgery is one thing that can be controlled with artificial intelligence and remotely operated. Now, these are certain things which can come in future. Like Dr. Mohan said about 3D imaging, it's an amazing piece of technology. We had a very complex case where I went all the way to Gurgaon to get this 3D printing done. And it was a very complex where I could plan my operation at least 20 times before I really tried in the patient. And when I tried in the patient, it was so smooth, it was so simple. So all these technology makes I would not say easy for doctors, it makes patients' life very comfortable. And of course, doctors do get benefited by this because the procedure is simpler. But my take on this is the future of cardiac surgery is transcatheter. Thank you.
Thank you so much. You have well covered the future. It's only that is no invasion, not only minimally invasive. Minimal invasion, that is the thing that minimal injury to the patient always being enjoyed both by the patient as well as the doctor. And this robotic surgery also now is becoming possible. Anybody from any part of the world can guide. That improves the doctor's leisure time. That is what they say. Otherwise, doctor is never relieved from his duty, either in all these serious issues. The third component we would like to learn is, what is the future of drug therapy in some of the cardiovascular issues? I am more focused on cardiac failure, heart failure. Earlier, digoxin was the intravenous drug. When we were all interns, we are given intravenously with furosemide. Now, digoxin is very rarely used in cardiac failure management. Various types of diuretics have come, inotropes have come, now intra-aortic balloon, so much has come. On the drug therapy, what I was appreciating is about the ARNI group of drugs and this, SGLT2 inhibitors, whether it is a cardiac drug or a diabetic drug, but very useful in clinician. We would like to hear the views of Dr. Mohanan and Seth.
Let me just say that I think the biggest advancements equally have happened in the drug therapy of every cardiac disorder, be it coronary artery disease, be it heart failure, over the last 10 to 15 years. Fascinating, Dr. Mohanan will agree, that we've watched the transformation of medical therapy, just like we've watched the transformation of interventional cardiology. 30 years ago, there was no beta blockers for acute MI. There was no thrombolysis for acute MIs. I still remember the first trial of thrombolysis for streptokinase for acute MI, and you remember that as well. And where are we now? We actually say there have to be 5 drugs which have to be given to a heart failure patient. And the most recent ARNIs and SGLT2 inhibitors have been very fascinating aspects of progress. That is why I say that nothing has lagged behind in the treatment of cardiology, be it coronary artery disease. What about statins? What about antiplatelet agents? What about ACE inhibitors? We have so many drugs which change, alter prognosis in our patients. So when we look at this whole sphere, we say, I tell you what's lacking at the moment is, again, artificial intelligence for diagnosis as well. So that's a very important aspect. Prescriptions. Now there are enough guidelines on which artificial intelligence can actually work. Unfortunately, you will be surprised to know, and you know it yourself, that guideline-directed therapy, be it for heart failure, be it for coronary artery disease or other disorders, is given only to 25% of the people in any country. Perhaps even the most advanced countries, you'll find guideline-directed treatment in only 40 to 50% of the patients. Actually, artificial intelligence could have done better than human intelligence in giving the right treatment and the right combination of drugs for the common disorders of heart failure and coronary artery disease, preventing infarctions, preventing readmissions, and preventing death. Now, those have been guideline established, and therefore, I think the future, at least in drug therapy, is going to rely immensely on artificial intelligence to say, is this guy completely covered? Are we sure we've given him guideline directed? Are we sure that he's adequate dose of statins so that he's got his LDL cholesterol to 70? And if he's a young person who's actually had frequent MIs, have we got it down to 40? There will be a red bleep coming. There will be an artificial intelligence telling him that his dose of statins need to be increased. Those are the real issues which are going to go into the future, saying we have to develop both preventive medicine and personalized medicine in a much bigger manner. And that's going to come very well from drug therapy as well.
Dr. Mohanan,
I will just take it up from the last point. Most importantly, Professor Said said, see, we see people when they have diseases. Now, it would be wonderful if when the physiology alters, when the pathology begins, if we can pick them up. That possibly is, and that is the area that we have. We have newer biomarkers. When people are getting PCSK9 during acute coronary syndrome, not later. Maybe we will start giving inclisiran when it comes. So I think the medical therapy in ACS, in heart failure, is progressing so fantastic. And of course, you said about the foundational therapy now being changed. Now you have to have a beta blocker, ARNI, and an SGLT2 and an MRA as a foundational therapy for a heart failure, whether he is a diabetic, whether he is not a diabetic. So we have taken over SGLT2 and maybe soon GLP agonist also. We don't know that yet. But so I think it's a tremendous, and again in heart failure, even though the cell-based regenerative therapy was a failure, I think there's a lot of interest now being given, growing a heart inside a sick heart. The concept looks very fascinating. And I would definitely love to see the coming back of the cell regeneration in heart failure. Not to speak of course, my surgical colleague has been mentioning about the importance of the LVADs. And now I was just reading, you have a LVAD sort of thing which you can put in descending aorta. Mind you, I can't imagine this small thing which can be put in descending aorta that will work like a HeartMate 2 or a HeartMate 3. So I think the progress has been tremendous in coronary artery disease and heart failure. I mean, of course, when compared to others, unfortunately, rheumatic heart disease still is remaining like that, but then possibly we are trying to conquer that also.
Thank you so much. Ajay Kal has some information on this regenerative medicine, heart within heart. Something you could comment on that?
So far as these newer medications are concerned, I can only tell you one thing. I have observed firsthand these patients of heart failure. You know, when we all have transplant list. We have patients with heart failure on the transplant list. What was surprising was around 3-4 years back when these ARNIs just came in the market. After around, say, 6 months of giving this ARNI and other medications, of course, guideline directed medication, and having our heart failure clinic and one heart failure expert cardiologist managing these patients, my cardiologist comes to me and tells me, sir, we had around 14 patients on the list, but now there are only 7. I said, why? He said, ARNI has done a magic. Most of our patients are off the transplant list because they are doing better. If I do their 6 minutes walk, if I do their oxygen consumption, it's much, much better. So this is the proof that we have much better medicines which save these patients from undergoing complex procedures like LVADs, transplant, and other things. So definitely there has been a tremendous progress in newer medicines, and this is what has changed many things. Not only that, this SGLT2 inhibitors, which has come in the market. Now, this is not only in HFrEF, it works also on these patients where you have preserved myocardial ejection fraction. Now, this is amazing because you know what you are going to do? You are going to prevent these patients from getting into terminal heart failure. And these are the things that ultimately, what is our goal? Our goal is to prevent hospitalization. See, you cannot make them immortal. What you can do is prevent multiple hospitalization. And to begin with, this symposium, which was there, our symposium is on how to diagnose these patients remotely, even if they are not coming to the hospital, how to manage them when they are at home, how to prevent their hospitalizations, and the newer medications. And this is the whole thing about. So medicine, in the medical field also, there has been a tremendous growth. My only one thing that I would like to say is we should have more and more diagnostic labs in remote corners of this country. That is very, very important. Connectivity and diagnostic procedures. Specialists can stay wherever they are, but diagnostic we have to spread to almost the whole country. This is my opinion about it.
Thank you so much. This is a fact agreed by cardiologists also. The number of patients who are, being put for a cardiac transplant are coming down. Clinically, I have seen all the cardiac sizes are all coming down. Ejection fraction has improved so well. And that's the way our RNA and SGLT2 inhibitors are working. Sure, that will further, decrease the number of, heart transplant. In the transplant side, you are an excellent transplant surgeon, sir, a long experienced surgeon. And what do you think the future is going to be?
See, unfortunately, transplant is not the future. because the number of donors are going to remain the same. The number of cases that are being done are static. I mean, we have seen no growth in transplants at all. India, of course, because we were not doing anything. So now we can see an explosion and lots of centers doing it. But the number of transplants are not going to grow. The future of managing heart failure will be an artificial device. Either it can be medically treated, or it can be a device that can unload the heart. And I would say another thing. You don't need left atrium, you don't need mitral valve, you don't need left ventricle. What you need is a single chamber. It's only inflow chamber. And then you have a pump, small pump connected. It ejects the blood. So you need nothing. What is heart? It's just to collect blood. If you have well synchronized two pumps, finished. No need of heart at all. That's the future.
Great.
Thank you.
So nice to hear. Now I think we have covered the three major areas of, the remote monitoring, artificial intelligence, and cardiovascular therapeutics, and a transplant. I'm so much thankful to you, Dr. Ajay Kal, that future is going to be with, small pumps and reservoirs only. Now, before we close, can I have a comment, a last final comment from each one of us? Now we'll start from Dr. Mohanan. On the future of cardiology, what you would like to say crisply, sir? One or two comments.
Okay. I think there is a tremendous, even though the future prediction depends, on your power of imagination, but yesterday's fictions are today's realities, and there is a tremendous improvement in the field of cardiology, whether it is the acute coronary syndrome management, cath lab management, heart failure management. But these are the three areas, and interpretations of applications of machine learning and artificial intelligence, knowing things earlier, diagnosing the disease before it sets in a patient is happening. And I think we should grab this opportunity and learn all the nuances of it and save our patients. And it's very interesting to have a 3D printing of my patient's heart so that I explain everything to him. And that will be a wonderful thing to happen.
Great. Thank you so much. Dr. Ajay Kal, what will be your final comment on cardiovascular surgeries in the future of cardiology?
See, my comment would be, for every bad thing that happens, there is a good aspect of it. COVID has what we could have done around 10 years later. COVID has taught us. Most of my consultations are now online. I see patients, I prescribe them. So it has brought us more closer to the futuristic medicine. And today we are discussing this. Let me tell you one thing. It is a matter of time that most what we are discussing today will be a reality in near future, not distant future.
Sure. Thank you so much. Thank you very much for all the three faculties for sparing your brain, knowledge, mind, and time. And the future of cardiology will be, number one, artificial intelligence. Number two, remote monitoring systems. Number three, minimally injuring the patient surgically. You will have a transcatheter interventions or an efficient drug therapy. This will be the future of cardiology. Sure, all our cardiac patients will be benefited with these interventions. With profuse thanks to all the participants, let us close today's discussion. Thank you all.
Very much. Thank you.